Nutrition. You can use the 4-2-1 rule to estimate maintenance fluid needs for children based on their weight. For the first 10 kilograms, you need 40 cc's per hour. For the second 10 kilograms, you need 20 cc's per hour. For any additional kilogram after that, it's 1 cc per kilogram per hour. So for a 25 kilogram child, you need 40, then 20, then 5 to get 65 cc's per hour. Multiply that 65 by 24 to get the total maintenance needs for the day. For a 50 kilogram child, you need 40, then 20, then you have 30 left over to get 90 cc's per hour. If your rate exceeds 100 cc's per hour, then just cap it there. For fluid losses, multiply the deficit that you're given by the weight to calculate the additional volume that's needed in liters. If the 50 kilogram child has a 5% deficit, he needs 2.5 liters per day of fluid in addition to his maintenance needs. For calories, you can use the 100-50-20 rule. For the first 10 kilograms, you need 100 calories per kilogram. For the second 10 kilograms, you need 50 calories per kg. And then for any leftover after 20, you need 20 calories per kg. So for a 70 kilogram baby, you need 700 calories. For a 15 kilogram baby, you need 1,000 for the first 10 kilograms, and then you do 50 times 5, which is 250. So the total need is 1250 calories. For a 25 kilogram baby, you need the basal 1000 and then 500 for the second 10 kilograms. And then your leftover is 5 kilograms, which you multiply by 20. So then you get a total of 100 plus 500 plus 1000 or 1600 calories. Whey is the best protein, and the best sources of it in order of concentration are colostrum, breast milk, formula, then cow's milk. Newborns need 2 grams per kilo per day of protein, and premature newborns need 3.5 grams per kilo per day. By about 6 months, babies only need 1.5 grams per kilo per day. Consumption of long-chain fats is important for acquiring essential fatty acids. Deficiency in essential fatty acids presents within 2 weeks with scaly dermatitis, alopecia, thrombocytopenia, diarrhea, poor wound healing, and growth failure. Premature infants can have issues digesting fats because of decreased bile salts, so they commonly receive MCT oil. Deficiency in thiamine or vitamin B1 causes beriberi. Wet beriberi describes heart failure and edema. Dry beriberi presents with neuritis, anorexia, and irritability. Wernicke-Korsakoff syndrome describes alcohol-related thiamine deficiency and beriberi. Deficiency in riboflavin or vitamin B2 causes glossitis, seborrheic dermatitis, anemia, and angular stomatitis. Ocular symptoms of riboflavin deficiency include photophobia, loss of acuity, itching eyes, and corneal vascularization. Infants who need phototherapy can develop a riboflavin deficiency and start to show these ocular symptoms. Deficiency in pyridoxine or B6 can cause peripheral neuritis, sideroblastic anemia, seborrheic dermatitis, tongue swelling, and can cause seizures in infants. B6 deficiency is associated with isoniazid, so patients receiving this for TB treatment may also need pyridoxine supplementation. B6 toxicity is associated with neuropathy and ataxia. B12 deficiency is associated with macrocytic anemia with hypersegmented neutrophils, ataxia, and peripheral neuropathy. Vitamin C deficiency is associated with gingivitis, poor wound healing, and osteopenia. Vitamin C toxicity is associated with GI upset, kidney stones, and it can cause hemolysis for patients who have G6PD. Deficiency in niacin, or B3, is associated with pellagra, which is diarrhea, dermatitis, and dementia. The buzzword of a diet containing a lot of corn indicates a setup for a niacin deficiency. Patients with heart nut disease can have pellagra as well, but this is from an issue with tryptophan transport and absorption. Niacin toxicity causes flushing, tingling, itching, dizziness, nausea, and transaminitis. Deficiency in folate, or B9, causes glossitis, diarrhea, neural tube defects, macrocytic anemia, and leukopenia. Goat's milk is deficient in folate, and methotrexate use impairs folate absorption. Biotin deficiency causes a rash, glossitis, muscle pain, alopecia, ataxia, and coma, and it's important to remember biotin deficiency associated with lactic acidosis. The fat-soluble vitamins A, D, E, and K need pancreatic enzymes and bile acids to absorb. Patients with pancreatic insufficiency, short gut, renal disease, or prolonged antibiotics use can become deficient. With vitamin A deficiency, which is retinol, patients have blindness, Bitot spots on the conjunctiva, follicular hyperkeratosis, and impaired infection resistance. With vitamin A toxicity, patients have carotenemia, alopecia, dry skin, bone pain, hepatosplenomegaly, and it's important to remember vitamin A toxicity with pseudotumor cerebri with increased intracranial pressure. Vitamin D deficiency causes frontal bossing, epiphyseal widening, long bone bowing, rachitic rosary, and craniotabes or soft skull bones. Vitamin D deficiency is also called rickets. Initially, phosphorus will also be low until parathyroid hormone increases to break down bones and increase the calcium and phosphorus. If the phosphorus is low and the patient appears to have a vitamin D deficiency, consider X-linked familial hypophosphatemic rickets, which you treat with vitamin D as well, but also you need phosphorus supplementation. If vitamin D deficiency is caused by poor gut absorption, the 25 vitamin D will be deficient. If the kidney is not converting absorbed vitamin D into the viable type, 125 vitamin D will be deficient. Vitamin D toxicity can cause hypercalcemia and subsequent diuresis, abdominal pain, constipation, and seizures. You treat vitamin D toxicity the same as hypercalcemia with fluids and Lasix. Vitamin E deficiency causes hemolytic anemia, jaundice, peripheral edema, ataxia, hyporeflexia, weakness, and retinal dysfunction. Associate vitamin E deficiency with TPN. Vitamin K deficiency can cause easy bruisability and hemorrhage. The vitamin K dependent coagulation factors are 2, 7, 9, and 10. Protein C and S are also dependent on vitamin K. Infants who don't receive vitamin K in the delivery room are at risk for bleeding, formerly called hemorrhagic disease of the newborn, usually around day 2 to 7. Since factors 2, 7, 9, and 10 are in the intrinsic pathway measured with PTT and the extrinsic pathway measured with PT, both of those markers will be prolonged. If bleeding in a neonate occurs before that 2 to 7 day mark, it may actually be that the mother's taking warfarin or medications for TB or seizures. If it occurs later, consider if the infant needed antibiotics that are interfering with vitamin K absorption. FFP has broad factor repletion capability and can be used for treatment along with vitamin K itself. In the United States, iron deficiency is the most common nutritional deficiency in children. I discussed this more in the hematology video, but I wanted to emphasize that formula needs to be iron fortified. Selenium deficiency is associated with cardiomyopathy, myositis, macrocytic anemia, and lightened hair and skin. Zinc deficiency classically causes a perianal and perioral scaly rash, poor wound healing, anorexia, poor taste, and diarrhea. Patients with acrodermatitis enteropathica have a zinc transporter defect and present with a more severe version of the zinc deficiency symptoms. Copper deficiency can cause microcytic anemia, neutropenia, bony abnormalities, and lightened hair and skin. Menkes X-linked kinky hair disease of impaired copper absorption causes neurodegeneration, hypotonia, seizures, bony abnormalities, kinky hair, and lightened skin. With caloric deficit overall, patients have marasmus, wasting, hypothermia, bradycardia, like patients with anorexia. With protein deficit, patients are lethargic, they have muscle wasting, alopecia, rash, and edema. When you're refeeding someone who's been in a chronic caloric deficit, the typical starting calorie ranges are between 1,000 and 1,400 calories per day, and you increase by 10% every few days, with a goal of 1 pound max weight gain weekly. Watch out for needing to replete potassium, magnesium, calcium, and phosphorus. During a 4-month well child visit, your breastfed patient's mother states that she's on a lacto-ovo-free vegan kosher diet. What common deficiency might your patient develop? Vitamin A, vitamin C, B12, folic acid, or zinc? The correct answer is B12. A 16-year-old patient comes for yearly school sports evaluation. She complains of chronic intermittent headache, reduced appetite, and she has hepatosplenomegaly on exam. She's taking high-dose vitamins to help improve her softball skills. What toxicity might she have? Vitamin A, vitamin B6, vitamin B12, vitamin C, or vitamin E? The correct answer is vitamin A. This is getting at pseudotumor cerebri causing her intermittent headaches. Basal energy needs in a patient can be best calculated by weight, height, body mass index, body surface area, or head circumference. The correct answer is body surface area. Premature neonates should consume formula with increased short-chain fatty acids, medium-chain fatty acids, long-chain fatty acids, triglycerides, or trans fatty acids. The correct answer is medium-chain fatty acids. Here's some major takeaways from the video to hopefully bank some points on the exam. Basal energy needs are most accurately calculated by body surface area. Second to colostrum, breast milk has the highest whey to casein ratio, so better than formula. Premature infants need formula with MCT because they have decreased bile acids. Breastfed infants of vegan mothers are susceptible to B12 deficiency. Goat's milk is folate deficient. Vitamin D deficiency presents with constellation of epiphyseal widening, thickening of the wrists and ankles, costochondral beating or rachitic rosary, long bone bowing, and cranial tabes or soft skull bones. Acrodermatitis enteropathica is an autosomal recessive disorder in zinc absorption, so they'll present like zinc deficiency. With copper deficiency, you might be tested on Menkes X-linked kinky hair disease, which will present with kinky hair, but also with light pigmentation. Vitamin A toxicity is associated with headache, anorexia, nausea, vomiting, hepatosplenomegaly, and bone pain, and then that headache was from increased intracranial pressure or pseudotumor cerebri. With those major takeaways, that is the end of the nutrition talk.